So, how do we treat reactive arthritis? Well, there's no cure, and for the majority of patients, symptoms will resolve on their own over time. But up to 40% can have a recurrence. So, the first goal of treatment is again to look for a possible underlying infection, and if it's still present, such as chlamydia or Campylobacter, the underlying infection should be treated. And then the second goal of treatment is symptom to control, right? Patients have joint pain and it hurts to pee and they have eye pain. And so the number one drug that has been poorly studied but it is widely used for the treatment of reactive arthritis is nonsteroidal anti-inflammatories. And so a potent nonsteroidal anti-inflammatory such as indomethacin 75 milligrams twice or 3 times a day or maybe diclofenac should be used. Although there's really only been 2 small studies evaluating the efficacy of nonsteroidals for the use of reactive arthritis. There's many years of experience by clinicians worldwide, and it appears that they're very effective. In addition, again, if chlamydia is either identified on culture or strongly suspected based on history as the inciting infection, doxycycline 100 milligrams twice a day for up to 3 months is recommended, as has been shown to both shorten the duration of symptoms, specifically of the joint symptoms, and reduce the incidence of recurrence. Now, patients with large joint effusions, so patients who have hip joint involvement or knee joint involvement and have really severe symptoms, do benefit from intra-articular prednisolone injections. And so those are your first line treatments, basically. The non-steroidal anti-inflammatory drugs, possibly doxycycline if chlamydia is suspected, as well as steroid injections for hip and knee joint effusions that are very severe. Now, if patient symptoms don't improve after using initial therapy, subsequent therapy for persistent disease can include things like sulfasalazine at 1 gram twice or 3 times a day, and this has been shown to be effective in both HIV positive and negative patients. As well as low-dose oral steroids can be used. Especially, they've been shown to be especially effective in treating the extra-articular manifestations, such as iriditis or uveitis, and in HIV patients, the skin findings of the keratoderma blenuragicum and the circinate bilantis, which we just talked about, the findings on the feet and the penis. And then, in addition, in HIV positive patients, initiating antiretroviral medications has been shown to dramatically improve disease. And so this could, in a patient that doesn't otherwise qualify to initiate antiretroviral medications, the presence of reactive arthritis should definitely urge you to start them earlier. And then third line treatment for patients who develop chronic disease, which is uncommon but can occur, include things like infliximab, methotrexate, TNF-alpha inhibitors. But again, the use of these medications should really be reserved to very experienced clinicians and subspecialists.